Hello guys, so this is a new thing I'm trying to experiment with, trying to help you learn a little bit about ECGs from wherever your knowledge is, trying to maybe add something to it, add something to my own knowledge, and I hope the seniors in the group will help me and you guys also if I make any mistakes while in these lectures or on the group. So yesterday or like some days before, I guess, I had put an ECG on the group, and with the description of it being of an elderly male with a known case of COPD, complaining of chest pain. So broadly, what we can see from the primary ECG is that there is some tachycardia, and when there is tachycardia you can see the rate is variable, but somewhere between 150 to 300, and comes around average 200, suppose. I hope you all know how to calculate the rate of an ECG. We can discuss that someday later. We can also see that it is irregular. Then the next step for such kind of ECG is to see whether it is broad complex, narrow QRS complex. So narrow QRS complex will be less than 120 milliseconds, that is less than 3 small boxes. And we can see that it is generally less than 3 small boxes. So we can broadly say that the rhythm is originating from the atrium. Now, if it is originating from the atrium or somewhere along the fast bundles, something along the mm, along AV node, bundle of his, Purkinje fibers, then let's look for P waves to see if it is originating from the atrium. And as we can see, there are some areas where we can see some P waves, which is somehow here in this part. Let me get a pen. Yeah, this is a P wave. There are P waves here, here, and here. So P waves in lead to V1 are the lead 2 and V1 are the main leads where we see the P wave and look for it. And there are other waves that you might see which don't really have a P wave, which are like this. So there is no clear distinguishable P wave. One other important thing is to see that if there is an isoelectric segment in the ECG, which is this, if this is there, it is not atrial flutter, which is an important differential diagnosis for this. Atrial flutter with aberrant conduction because it is irregular. But anyways, going ahead, we can see that there are multiple P waves of different morphology. That is also an important point. So this is possibly a ECG of multifocal atrial tachycardia. We will see in detail what is it about, but in brief I would say that there are 3 different kinds of P waves with tachycardia being present, of course. And the rate is also, the rhythm is also irregular. But also, this is not classical MAT, as there are some waves without P waves, but that can be attributed to junctional rhythm also. So there are impulses from the atria and there are impulses which are going from the AV node, I guess, or just below the AV node from bundle of S. That's why it is narrow complex and still doesn't have a P wave. Now, after some time, this same patient had a ECG like this. Now, this is lead 2. The entire waveform that we see in all 3 rows is lead 2. There are some complexes where there are P waves, as I have highlighted here. This is more obvious to see that the P waves are of different morphology, and there are some waves without P waves, and there are some QRS complexes that are broad complex QRS complexes. This, for example, is a broad complex QRS complex here. This also is one, this also is one, This also is. So, such broad complex QRS complexes. Now, what to do about those? Those come from the ventricular muscles and not from the fast fibers, I guess. So, this patient is someone which has lots of conduction abnormalities with no real pacemaker and jumping all over the place. So this can be called as multifocal atrial tachycardia with multiple ectopics coming from the junction system and the ventricular system. It doesn't really have a clinical diagnosis as such, and if the patient has chest pain and other stuff, we can, at least according to my knowledge, I would suggest this patient to go for an EP study and get an pacemaker implanted. But if I'm wrong, I hope our cardiologists will correct me in this. Moving over to a brief about multifocal atrial tachycardia. Okay, it is a rapid, irregular atrial rhythm. I will get my pen. It is a rapid, irregular atrial rhythm arising from multiple ectopic foci within the atria, most commonly seen in patients with severe COPD or CCF. Now, as we saw, COPD was one of the things that was there in our patient. Okay. And then it is typically a transitional rhythm between frequent premature atrial complexes and atrial flutter and fibrillation. So, the rhythm can transform into one of the two. ECG features are heart rate more than 100, usually 100 to 150, can be as high as 250. Irregular rhythm, we saw that, varying PP, PR and RR intervals. Three distinct P waves. This is an important part in the same lead. Then isoelectric baseline, as we saw. No flutter waves are there. Absence of a single dominant atrial pacemaker, that also is there. There is no just one P wave that is there, that is common. And other P waves are not really conducted, aberrantly conducted to the ventricles. Clinical relevance usually occurs in seriously ill elderly patients with respiratory failure, like COPD and CHF, tends to resolve following treatment from underlying disorder, and development of MAT during an acute illness is a poor prognostic sign. Associated 60% in hospital mortality and mean survival of just 1 year. So, important as a prognosticating marker. Death generally occurs due to underlying illness. A mechanism of MAT arises due to a combination of factors which are basically right atrial dilatation, corpus which we saw in COPD patients, increased sympathetic drive, hypoxia, hypercarbia, beta agonist, theophylline. So these are some important points that you need to remember. For COPD patients also, we prescribe drugs, especially Diolin Budecort, especially Diolin, or if we give aminophylline. These are prone to generate arrhythmias and tachycardias. So tend to look at ECGs first and then think twice before you prescribe those drugs. Hypokalemia, hypomagnesemia are also one of the causes. Okay. ECG example, as we can see, the arrows pointing to the P waves show different morphology P waves with rapid irregular rhythm and three distinct P waves. One more ECG, irregular rhythm with different P waves and also right axis deviation, prominent R wave in V1, deep S wave in V6, suggest RVH. That was also one of the things that we can see for call pulmonary. The QR complexes in AVI is also something indicative of RV load. Okay, I hope you understood what the small topic was about. Give me feedback on how you thought the lecture was, and I look forward to your contribution in the group, which nobody has done, but please do.